All right, this is medical nutrition therapy for metabolic stress, including sepsis, trauma, burns, and surgery. Take 2. All right, so our concern here, injuries that can result in significant metabolic complications. And so what we're looking at, we're looking at basically ICU patients with a subset of conditions. So we're looking at things like sepsis, trauma, burns, and significant surgery. All activate a systemic stress response. The physiological and metabolic outcomes may lead to shock and other negative outcomes. And so a compromised nutritional status creates a vulnerable immune system, making it difficult to mount both a stress response and an immune response when confronted with metabolic stress. And so what we're looking at is, again, we have to separate this out. And so this is based on the Aspen guidelines. But so there's research studies that help us understand which of these patients should be fed, what nutrients should we be feeding them, when do we initiate the feeds, and then if we are feeding them, how much of that formula are we going to feed them? So nutrition support's a crucial component for critically ill patients. Again, our goal here with ICU patients is to preserve lean body mass, so we'll talk about protein, maintaining immune function, avoiding metabolic complications, and reducing stress, inflammatory, and immune responses, and prevention of cellular injury. So first, let's take a look at metabolic stress. So here we have a hypermetabolic catabolic response to acute injury or disease. And so the degree of metabolic stress correlates with the seriousness of the injury. So this goes all the way back to MNT1, where again we saw that change in CRP and that change in albumin is based on the degree of insult, which is the worse the injury, the worse the metabolic stress, the worse the albumin and CRP. So diagnoses that can lead to metabolic stress can include gunshot wounds, motor vehicle accidents, closed head injuries, burns, severe inflammation, cancer, sepsis, hypoxic injury, necrosis, and significant surgeries. And so this isn't, for example, if you ever had to go to the doctor's office and get, a mole taken off. I mean, we're talking about significant OR surgeries. So look at epidemiology and how frequently these occur. So unintentional injuries and motor vehicle accidents are ranked as the 5th leading cause of death in the US. Now, again, and what we have to look at is what the stats are telling us, because trauma is the leading cause of death for young people, accounting for 70% of all deaths for those aged 15 to 24. So trauma being defined as an injury caused by physical force. So what you'll see is that unintentional injuries and motor vehicle accidents aren't the leading cause of death, because again, what you have to look at is how many elderly are in the US population. So then you look at your leading causes of death with things like cardiovascular disease. It makes a lot more sense. But when we take a look at young people, right? So young people typically don't get cardiovascular disease, they don't get the severe diabetes, etc., etc. So trauma is the leading cause of death. Now, what you'll notice is what's interesting about that age bracket is, again, we could go through and see that this data is still slightly skewed. And so what you'll see is that, for example, you'll notice that males' insurance, so when a male gets their permit, their learner's permit for learning to drive with their parents until the age 24, right, until when they finally turn 25, you'll see a significant decrease in insurance costs. And again, what this does is this parallels the fact that, right, most of our motor vehicle accidents are going to involve males, right, from 16 to 24. And so after that, you see a significant drop off. So what you see is you see the frontal lobe develop, you see better decision making and safer driving. All right, so the 3 phases of the stress response. So we have the ebb phase, which occurs 2 to 48 hours immediately after the injury. So it's characterized by shock, resulting in hypovolemia and tissue hypoxia, decreased cardiac and urinary output, body temperature, and oxygen consumption. And so our goal is to restore blood flow to the organs, maintain oxygenation of the tissues, and stop any hemorrhaging. The second phase is the flow phase. So as the patient stabilizes, fluid is resuscitated. This is characterized by increased cardiac output, increased oxygen consumption, body temperature, increased or hypermetabolism, and total body protein breakdown or catabolism. And then finally, we have the recovery phase. And so we have the resolution of stress with a return to anabolism and normal metabolic rate. So let's take a look at the review of response to starvation. So the body responds through physiological adaptations to starvation. And so the body responds to the reduction in food intake by reducing its overall energy needs. And so the fancy word for this is adaptive thermogenesis, which is your metabolism is actually going to decrease. So basal metabolic rate is going to be reduced with fewer calories needed. And the primary fuel source will transition to fats, This is the infamous ketosis, as carbohydrate sources are depleted. And so then amino acids are spared to preserve lean body mass. So after about the first 48 hours, amino acids are going to be preserved because, again, we can't manufacture them. We can only change their form and shape. So if we're truly starving or in starvation, with no food, then amino acids need to be preserved so they can be converted into the necessary proteins. So here we can see the metabolism response to starvation in the short term with no injury or stress. So again, this is in the normal state. If I were to reduce your calories, what you would see is that the metabolism would go down. You would see a transition, So we'd be using up our glycogen stores. So we'd be then increasing our gluconeogenesis for carbohydrates, and we would begin transitioning to using fat as our energy source with ketones and ketosis. What you'll see minimal catabolism to meet glucose needs, and again for transamination or converting those amino acids into other appropriate things like enzymes for energy reactions, looking at the protection of the visceral organs, etc. So you would see a loss eventually of lean body mass in the form of skeletal muscle. But again, for the most part, your body's smart enough to conserve this with the exception of serious need. And so here we can see looking specifically at fuel substrates. And so here we can see the interaction with hormones. So again, what we're going to see, you can see that function of the glucose triggering the pancreas with, again, a release of, in this case, insulin, but could be glucagon if we needed to increase glucose. And again, you're going to see, we're going to start breaking down the adipocytes and using fatty acids for energy, in the conversion of ketones, as opposed to primarily relying on glucose for energy. So the comparison of metabolism during normal nutrition versus starvation. So again, we have a nice little cheat sheet. So again, metabolic rate matches current physical activity requirements and body composition. In starvation, we're going to have a decrease in metabolic rate to then, hopefully meet energy needs, assuming that some amount of energy is available as opposed to none. Again, a transition away from glucose towards fatty acids with using, lipids as our main source of energy. Protein being used, normally for the maintenance of protein structures and to meet protein synthesis needs. Again, preservation of lean mass, minimizing protein loss. So again, continuing on, so stress and injury activate the hormones that direct a fight or flight response with the primary purpose of mobilizing nutrient stores to meet immediate energy demands. So again, when your body is stressed out, it doesn't determine or distinguish why it's stressed. But typically, when you have this fight or flight, you have this adrenaline dump, Your body has to do something to, in an emergency, to protect itself. So we're going to have a release of glucagon to promote gluconeogenesis, amino acid uptake, and protein breakdown. Cortisol is going to enhance, again, that skeletal muscle breakdown, but promotes the use of amino acids for gluconeogenesis, glycogenolysis, and acute phase protein synthesis. And epinephrine and norepinephrine are going to increase energy availability by stimulating glycogen breakdown and increasing fat breakdown and the release of fatty acids. So again, this all seems like a very negative thing, but again, you got to look at it in context, which is in a survival situation when we need lots of energy, these hormones make sure that we have lots of energy, Your skeletal muscle doesn't really matter if you get caught by the bear or the lion, etc. So instead, we need to increase our energy availability, run away and regroup, then these hormones should subside and decrease. So here we can see again, so going through all of the systems just a little bit more in detail. So that metabolic response during stress. So again, we can see changes in the liver, the central nervous system, the muscle, the intestine, and the endocrine system. So you can see which hormones, are all increasing. You can then see, in circulation, which nutrients are going to go up, which are going to go down, and changes in liver metabolism. So what we do know and what we see, so again, we spoke about all of this cortisol, this glycogenolysis, this glucose breakdown, And so what we see is we do see hyperglycemia and insulin resistance. So we see increased glucose uptake due to gluconeogenesis and diminished insulin. So remember, right, there are specific cells that do not require insulin. So we actually have insulin resistance, but the cells that truly need it, for example, exercise and skeletal muscle to help you run away, does not need insulin to absorb this glucose. So in essence, this insulin resistance protects the glucose from being stolen by other non-essential systems. But your blood cells, your brain, your exercising skeletal muscle, all can take up this glucose without insulin. So again, the insulin resistance is not really harmful in the immediate, right, try to save your life response. Now, this can be a problem in the ICU because, again, we fixed everything, but your hormones haven't returned to normal. But out in the wild, right, this is a beneficial response. So we see an increased lipolysis with elevated catecholamines and cortisol. And so this results in increased circulation of fatty acids and decreased lipogenesis, right? We're not going to be storing fat while we're having this fight or flight response. So positive acute phase proteins are mobilized in response to an injury or infection. Again, these aren't good or bad. This just means they increase during a stressful response. So our positive acute phase proteins include C-reactive protein, ceruloplasmin, fibronectin, and serum amyloid A. And so again, long-term, right, if this isn't going to resolve, this results in a loss of lean body mass, hypercatabolism, increased protein breakdown, increased gluconeogenesis, and an increased net negative nitrogen balance rate loss of protein. And so complications include immunosuppression, increased infection rates, delayed wound healing, and increased risk of death. So again, this is why in the short term, this may protect you, but our goal is to mitigate this in the ICU. Now, I spoke a little bit about these previously, but looking at cytokines, and so here they regulate the release of acute phase proteins. And so cytokines are kind of like localized hormones, so they affect the behavior of other cells nearby. And so cytokines are released by phagocytic cells in response to an injury or stress. And so the pro-inflammatory, right, the ones that get a lot of press are going to be our interleukins 1, interleukin 6, and tumor necrosis factor. So here we see catabolic insult-induced protein energy malnutrition. So protein energy production are abnormal. So here we have, right, in essence, a stress on the system. And so what we actually have here is an increased metabolic rate. No adaptive response has been activated. An increase in glucose production. So again, we have that insulin resistance and an increase of circulating glucose. Here we can see, right, so looking where our energy is being sourced from and what's being used. So energy production mainly from glucose and amino acids. So again, we saw that rapid loss of lean mass, which again, this is very negative long term. So we want to stop this process as soon as possible. And again, so that unbalanced hormonal response with excessive breakdown. Now again, this helps you survive in the short term, but this should improve and go away or be treated very quickly. If it's not, or if the injury is too severe for this to return to normal, right, that's when we have the problems that we see and the complications that we see in the hospital and the ICU. So a summary of metabolic abnormalities observed in the stress response. So increased levels of glucagon, cortisol, epinephrine, and norepinephrine, hyperglycemia and insulin resistance, increased basal metabolic rate, increased rate of gluconeogenesis, catabolism of the skeletal muscle, increased loss of urinary nitrogen, increased synthesis of positive acute phase proteins, and decreased synthesis of negative acute phase proteins. So things that we're looking for in the treatments for patients under metabolic stress. So again, based on the medical diagnosis and treatment, right? So the physician and the medical team are going to treat the underlying injury or illness. And so this can include those things like mechanical ventilation, antibiotics, steroids, continuous renal replacement therapy, insulin therapy, and then our role, nutrition support. But based on what we're prescribing, right, we have to understand how all of these different mechanisms or treatments, right, are going to affect our nutrition support prescription. So as clinicians, we need to balance, right, the prevention of protein energy malnutrition and preventing complications, right? So our big concern there is, right, as we know that the vent changes what type of nutrients we give somebody, steroids affect what type of nutrients we give somebody, so on and so forth. So we need to consider the patient's status prior to their illness, right? Their level of injury, any current metabolic shifts. And so again, and this is extremely important, is that nutrition status prior to injury is a predictor of mortality and morbidity. So how well nourished you are before you have an injury is a predictor of how sick you're going to get and how likely you are to die. So a previously healthy person may take 2 weeks to progress to protein energy malnutrition, but a person with pre-existing malnutrition may only take a few days. And so this is why you'll see a lot of times, even for elective procedures, right? They'll actually have a nutrition regimen for the first 2 weeks leading up to the surgery to make sure that you are as well nourished as possible before undergoing surgery. So here for a nutrition assessment for things to consider. So you have to look at the patient's diagnoses, medications, food and nutrition related history, including their intake, problems swallowing, nausea, vomiting, constipation, ability to self-feed, any changes in anthropometric measurements, and then again being able to look at their laboratory data and assess it right within that situation. So again, is the albumin elevated due to or depressed due to poor nutrition, or is it depressed due to chronic stress? Is it elevated due to renal replacement therapy? Right, taking a look at the hemoglobin, right, taking a look at your labs for anemias. Again, is this due to stress? Is this due to hemorrhage? Is this due to chronic illness? So on and so forth. So challenges with assessing a patient that's critically ill. So again, diet history and weight history may not be available. So again, if you have somebody who's just come in from a severe motor vehicle accident, right, they're not really able to give you a report on their past history, any diets they've been following, their nutrition status. Measured weight may not be reflective of actual weight with fluid shifts. Again, so especially right because of stabilization in the field, patients may gain significant fluid weight to help maintain their blood pressure. Biochemical indices to assess visceral protein status, again, are more likely to reflect the levels of stress and illness, not protein or intake status. And loss of lean body mass and fluid accumulation are very common in ICU patients. So ideally in this patient population, we will be assessing energy needs using indirect calorimetry. So whenever possible, we would like to use the metabolic cart. Now we do have though different options. So for example, the Penn State equation is accurate 70% of the time and more accurate than MSJ equation in metabolically stressed patients. But according to the AND, right, you could use either as there's not enough evidence to reject MSJ. You'll see that Aspen may recommend 25 to 30 calories per kilogram, but if the BMI is greater than 30, then we recommend 22 to 25 calories per kilogram of ideal body weight. And it's very important that that is ideal, and you'll see that that is bolded for you. So we mentioned previously that we needed to focus on the fact that this was ideal body weight. So let's talk about some other concepts, which is permissive underfeeding. And so here we're going to provide less energy than the goal estimated energy requirement in critically ill patients. So we're going to purposely give people less food than they need. And this is used to avoid the detrimental complications of overfeeding and reducing the risk of sickness and death. And so these side effects are things like hyperglycemia, azotemia, immunosuppression, hepatic steatosis, right? What we're saying is that all of those are more dangerous than whatever's going on with the patient. And so what we're going to see is improved metabolic control. Now, there's no agreement on the exact standard. So for example, one article recommends 18 to 22 calories per kilogram. And then the Aspen guidelines are 14 to 18 calories per kilogram of actual body weight, or 22 calories per kilogram of ideal body weight. So again, this is why actual versus ideal is very important in ICU populations. And so here we can again see some other potential benefits of permissive underfeeding. So lower omega-6 fatty acid intake provides reduced substrate for pro-inflammatory mediator synthesis. Limited carbohydrate intake may result in reduced hyperglycemia, lower nutrient oxidation, reduced DNA damage, and decreased hypermetabolism with resulting reduced CO2 production. So again, that adjustment. So again, going back to the pulmonary chapter for the production of CO2 from the metabolism of macronutrient substrates. When providing nutrition support to critically ill patients, it's crucial to avoid overfeeding. So again, we talked about these previously, these side effects: hyperglycemia, increased CO2, hyperglycemia with increased insulin requirements, respiratory distress, and respiratory acidosis. So it's best to underestimate, right? We can always give people more calories if they start losing weight. But again, if we give people too many calories early on and they have complications that sets them back or leads to death, we can't really adjust after that point. So many clinicians prefer to use ideal body weight in the obese population, although the Aspen guidelines do specify recommendations for obese, critically ill patients. For protein, we recommend 1.2 to 2 grams per kilogram, depending on baseline nutrition status, degree of injury, and metabolic stress. So again, open abdomen, burns, etc. The administration of excessive amounts of protein, though, will not improve the net negative nitrogen balance in hypermetabolic patients. So in case you're wondering, like, why do we stop at 2? If more is better, or if they have this much protein leaking from them, why don't we just give them more? We've tried it, it just doesn't work. So giving people extra protein beyond the 2 grams per kilogram in these metabolically stressed conditions does not appear to be beneficial. So vitamins and minerals. So needs are elevated during acute illness. So we have an increased urinary and cutaneous or through the skin losses, as well as decreased GI absorption, altered distribution, and altered carrier protein concentrations, which is, remember that most of these micronutrients are carried by albumin in the blood, but because of our metabolic stress, we have decreased albumin production, which means there's nothing for these micronutrients to bind to and travel through the blood. Fluids and electrolytes should be provided to properly maintain acid-base balance, adequate urinary output, and normal serum electrolytes. So the route of feeding, so oral is the preferred route, but often not possible, so many ICU patients are unable to eat. So then we go to our next option, which is going to be enteral nutrition, and then our third option is going to be parenteral nutrition, right, if we're unable to because of damage to the GI tract. So the timing, so enteral nutrition should be initiated within 24 to 48 hours of ICU admission and advance to goal within the next 48 to 72 hours. So you should start feeding someone within the first 2 days of being in the ICU. So again, looking at why dietitians work the weekends. If you come into the ICU Friday night, I should start your nutrition by Sunday night at the latest, ideally by Saturday night. And I should have you at goal nutrition, right? So if I started, so you came in Friday night, the latest I should start your nutrition is Sunday night, and you should be at full 100% of your needs being met by that following Wednesday, preferably earlier. Again, keeping the head of bed elevated. And so again, if we have high gastric residuals, we learned from the enteral chapter, we can advance the feeding tube right into the small intestine, so either into the duodenum or into the jejunum, and administer feeds that way. So again, if the GI tract is working, we still want to find a way to use it before we resort to using parenteral nutrition. And so here we have a nice heuristic on how to make these decisions, which is, so hemodynamically stable, which is the patient stable? No. Don't feed people that aren't stable. Is the patient stable? Yes. Okay, what do they have? Fistulas, vomiting, diarrhea? Yes. So basically, is there something specifically wrong with their GI tract? Is there a hole in it? Is it leaking, etc.? Use parenteral nutrition. No? Use the gut. Now again, you have to decide, is it best to use the stomach? Best to use the small intestine? Here's your starting guidelines. And then if there's any problems, switch to parenteral nutrition. And again, looking at how do we choose that route. So again, is determined based on the length of expected NPO status. So if it's going to be less than 7 days, depending on their BMI, we may just give them dextrose. If they're lower than 18.5 and it's going to be less than 7 days, we still may need to begin nutrition support. So if diarrhea is present, we want to determine the cause. Again, going back to the enteral chapter, we know that enteral nutrition is not always the cause of diarrhea. It can be due to hyperosmolar medications, antibiotics, an infection, hypermotility agents. So when choosing a formula, right, the most standard polymeric enteral nutrition formulas can be used for ICU patients. But we do have our immune modulating formulas with arginine, glutamine, omega-3 fatty acids, and antioxidants. Again, we've talked specifically about Oxiba with its high omega-3 content and inflammation, right, in our respiratory failure in our ARDS patients. Other formula additives, though, so things like glutamine, which is a non-essential amino acid, is the preferred fuel source, as we've spoken about previously, for the enterocytes. And so this is recommended for burn, trauma, and ICU patients, as the body, under these types of stressful conditions, can't synthesize glutamine as quickly as it normally could. Our branched-chain amino acids for isoleucine, leucine, and valine have shown improved nitrogen retention, decreased protein breakdown, and improved hepatic protein synthesis. We've already spoken previously about the fatty acids and omega-3s, EPA, and DHA, so their effects on inflammation and the immune system. And again, looking at our fiber in the form of probiotics, prebiotics, or symbiotics, right, to maintain a healthy GI tract bacteria. So again, for competition and preventing antibiotic-associated diarrhea. So MNT for metabolic stress. So again, our nutritional diagnoses and PES statements examples can include increased energy expenditure, increased nutrient needs, inadequate protein energy intake, altered GI function, impaired nutrient utilization, inappropriate infusion of enteral or parenteral nutrition. Now, I caution you with using this one. So in essence, if you're putting this, you're saying that the doctor has made a mistake and has chosen the wrong one. So even in the old versions of the manual, it will say use this one with caution. Inadequate or excessive intake from enteral or parenteral nutrition. So again, here we're just saying, hey, I'd like to change the rate, which is a lot different than saying, hey, doc, you should have never started this in the first place. And then inadequate or excessive fluid intake. So again, if we see right, that edema, that fluid accumulation, and we need to make a correction. And of course, the low-hanging fruit is altered nutrition-related lab values. Again, if they're in the ICU, almost everyone has altered lab values. So talking about some specific conditions, so we have sepsis, SIRS, MODS, and MSOF. So definition from the Society for Critical Care and Medicine. So sepsis is a documented infection and unidentifiable organism which causes an immunosuppressive response, preventing adequate response to infection. We have systemic inflammatory response syndrome. So sepsis without an infection describes widespread inflammation and may occur after surgery or trauma. And multi-organ distress syndrome or multi-system organ failure, so complications of sepsis and SIRS. And we have altered function in 2 or more organs. So let's take a look at some of the clinical manifestations for our patients with these conditions. So they'll be hypermetabolic, they'll have an increased white blood cell count, increased heart rate and cardiac output, alongside increased respirations or tachypnea with low oxygen consumption. They may have a fever or be hypothermic and be too cold. We'll see elevated CRP, fibrinogen, and acute phase proteins. Increased serum lactate, so they may have lactic acidemia, which is a form of metabolic acidosis with low blood pH, and so this occurs when our cells have too little oxygen. They'll have hyperglycemia, and we know that inflammation results, so we'll have vascular permeability, allowing fluid into the lungs, and the third spaces causing edema, right? So you'll see a swelling in the extremities, and fluid may fill into the lungs. And so we'll talk about septic shock. So severe sepsis worsens to the point of organ failure and hypotension. So this results in gut hypoperfusion, so hypo being not enough or low perfusion. And so the patient can develop an ileus, which is a lack of peristalsis or basically paralysis of the gut due to poor blood flow. Now, per Aspen guidelines, early enteral feeds help restore gut function, enhancing functional and structural integrity of the gut. And enteral nutrition may help maintain tight junctions between intraepithelial cells, which helps stimulate blood flow and induces the release of trophic factors. And so trophic factors are the molecules that signal to cells to develop and maintain connections with other cells, neurons, and to essentially stay alive. And so again, what we want is those trophic factors are going to be what encourages. So if we look at our cells as bricks, trophic factors are going to be what encourages and helps maintain the mortar to help keep the cells or the bricks glued together. So here we can see an example where again we see gaps in the cell or gaps in the mortar between the bricks, but we know that if we feed them and keep them nice and healthy, then we'll help protect this and keep the cells together. So the treatment is we need to treat the source of the infection or trauma, support the patient with ventilation, antibiotics, hemodynamic, renal, and metabolic support, so that's support for blood pressure, kidney function, and metabolism. Because of that hyperglycemia, they may need intensive insulin therapy. And alongside the nutrition support, we have to determine a way to accurately estimate nutritional needs, assessing for any abnormalities in metabolism, and determining fluid or volume restrictions. So again, our goal here is to use the gut with enteral nutrition, as again, this is going to help prevent mucosal atrophy and help prevent that loss of epithelial barrier function, again, maintaining those tight junctions through trophic factors. All right, so let's talk about trauma and open abdomens. This is kind of a really unique situation. So I've only seen this a couple of times in my career because it is kind of, conceptually, this is some crazy stuff. This is some high-level medical craziness, nutrition practice. So what we have is what's known as abdominal compartment syndrome. And so this occurs when there's an increased abdominal pressure due to increased fluid accumulation. So this occurs after major abdominal trauma or sepsis. And so what happens is, in essence, right, is that fluid is leaking into the abdominal cavity. And so we have to relieve that fluid or that pressure. And so what we perform is what's known as surgical decompression, which results in an open abdomen. So in essence, we literally fillet the fish, right? So they basically cut a very, very large incision in the abdomen and peel the skin and muscle back to allow the fluid to be removed. So this causes a loss of fluid, and with that fluid, right, a large amount of protein, as we discussed in the liver chapter. But what's going to happen is that slowly, as the swelling goes down, right, we'll kind of shimmy everything back in and then close the patient back up. But in the meantime, you are literally left in the ICU with your guts exposed. Now, what of course they do is they have a very, very special type of dressing that is placed over it. So it's like a plastic sheeting that protects you from bacteria, the air, etc. But we do still have some moisture loss and some elevated nutrition needs, both for the inflammation and the fluid. So this is pretty wild. So can you feed the patient enterally? So can you do a tube feed with their guts exposed? And so the answer is yes, as long as the patient is hemodynamically stable and not requiring large doses of medication to keep their blood pressure up. So pressors are vasoconstrictors that keep your blood pressure up so you don't go hypotensive and crash and have a heart attack. So as long as you're stable, yes. Now that being said, right, so this is from the Academy, a series of case studies, so that's just case studies. We haven't done this with hundreds of patients because this is that rare. But based on the case studies and the data that we do have, so a series of case studies indicates that enteral nutrition administered to patients with inadequate mesenteric perfusion may be associated with hypoxia and might promote the development of small bowel hypoxia and necrosis. So again, this is why we're very, very cautious, is that this is just case studies, but basically this can kill you. So you as the dietitian, right, are literally recommending life and death possibilities. So if it's the right patient, you're going to save their life. But if it's the wrong patient and we push for enteral nutrition, it could have deadly results. Now again, this is just case studies, so I can't show you that every single time we recommend tube feeds. It doesn't work that way. But just realize, right, when we're making these recommendations, right, we have to really know our stuff. This is not the time to... All right, so we've established that you can feed these patients. So let's take a look, though. So this is just some wild stuff because, again, I've seen these patients a couple of times in my career, but until you see this with your own eyeballs, I'll do the best I can to describe it. So we talked about, yes, you can use an enteral nutrition. Now, many of these patients will require parenteral nutrition. So if there's a discontinuation in the GI tract, aka there's a fistula, there's a hole, etc., or it's shut down. But if it's functioning, right? So if you have a fistula or a hole in your gut, so for example, let's say somebody has a gunshot wound to the abdomen. So we have filleted them like a fish. So we've opened up the muscle and the skin. We've now have the guts exposed. We've performed the surgery. We removed any shrapnel, etc. And now there's now a hole in the patient's intestines. Well, if it's high enough up in the small intestine, the surgeon will basically remove or clean off the raggedy edges from the shrapnel, and we will actually stick the enteral nutrition tube into the hole. So it will go from the pump, hanging in the room, and then bloop, and go directly into their intestines. Now, what we do have to work around is what's known as a wound vac. So to help the wound heal, we may use what's known as a wound vac. Now, a wound vac, so what it does is it conducts negative pressure wound therapy to promote wound closure. And so a sealed wound dressing with a vacuum is attached to it to draw out fluids from the wound, increasing blood flow. And these can be applied continuously or intermittently. Now, so what all that means is what we do is we conduct negative pressure. So especially here in the Deep South, you've actually been exposed to negative and positive pressure. You just didn't realize it. But if you've ever been in a building and what you notice is that the doors just won't seem to stay closed on the ground floor. They keep popping open, so especially the door to the outside. That building is under positive pressure. And so what that means is that the HVAC, right, the central air conditioning unit, has pumped so much cool air into the building to try and cool it off that the building is slightly pressurized. So it is positively pressurized, pushing the door open. So it's the 3 P's. Positive pressure pushing. So positive pressure would be blowing air on something or pushing air out of the room. Negative pressure is like a vacuum cleaner, right? It's sucking or drawing air or fluid in. So basically the wound vac is kind of like a pool cleaner, right? Where it has that big plastic sheathing to build suction, and then it's just kind of right, and it sucks along, and what we're doing here is, in which cases, we're sucking the slough and other metabolic waste products out of the wound. So here we can take a look at some examples. So these are examples of wound vacs. So what you'll see is that there's a large gaping hole in that abdomen, or that foot, or that abdomen, and so what they do is they take it's a piece of dense sponge that acts kind of like a filter. It is cut to shape. So you're kind of like cutting and tracing, right, like the tanagrams. You place it in the wound. You then place the plastic sheathing over it to seal it tight, and then they turn it on, and all of a sudden, right, it's just like sucking the air out of like a bag of Cheetos, or like if you've ever seen any of those food vacuums, right? And so again, what it's going to do is it's going to withdraw fluid and waste products from the wound to encourage faster healing. All right, so let's take a look at some other specific disease states. So we'll start with burns. So here we have a tissue injury caused by exposure to heat, chemicals, radiation, or electricity. And so results from an injury to the skin, but damage may extend into the muscle and bone. And so we have to think about, like, right, who's going to be having burn injuries most commonly. So what should have jumped into your head is, I hope everybody said firefighters, and you would be correct. But we also live in Florida, and so you'll see this, unfortunately, it gets posted in the news quite regularly during hurricane season, which is going to be linemen. And I don't mean football linemen, right? I mean people that work power lines. So, right, so when you have the power goes down due to a hurricane, right, so you have linemen in very dangerous conditions attempting to reconnect high voltage electricity, in which there's cases of high risk, right, of electric shock and burns. Now we're looking at how bad a burn is, right? So the depth of the wound and the percent of body surface area are we classify how bad these injuries are. And so what we use is the rule of nines to determine burn surface area. And so what we mean by that is to quickly estimate your body is divided into chunks of 9%. And so what you can see here, for example, is that the front of one leg is 9%. The back of one leg is 9%. So one entire leg is 18% of your body. The other leg is 9% on the front and 9% on the back of your entire body. Your arm, which is about half, give or take, about half the size of your leg, is 4.5% on the front, 4.5% on the back, or 9% total. So, right, one full arm is equal to the front half of one leg, so on and so forth. And so what this does is that you can quickly look at somebody and determine or estimate, right? Again, we're not trying to get super detailed with this, but if you've ever seen in movies when they say, oh, 40%, he had 40% of his bodies were covered in burns, 50% of his body was covered in burns, right? So on and so forth. This is how they actually come up with those numbers to quickly estimate how much of the body. So looking at our burn classification, so our first degree burns are superficial. So these involve reddened top layer of epidermis, and these heal quickly and easily. So this is your classic sunburn, right? You get nice bright red skin, but when you poke it, it should turn bright white, and then it turns back to red. Our second degree burns is superficial partial thickness, and so these are open or weeping wounds. And so this is, again, something that's been burned to the point that it blisters. Our third degree burns are deep partial thickness with destruction of the epidermis and dermis. And our fourth degree burns, right, is our full thickness burns. So these destroy all layers of the skin and involves underlying muscle, organs, or bone. And so we can see, right, so you can see when you go through the first layer of skin at the very top of the epidermis, the second degree burn, right, which is going to get a little bit lower. So this is things like pretty bad blistering, etc. Our third degree burns, though, you can see now we've actually gone below that. And so we're now looking at, so going into our subcutaneous fat, and then our fourth degree, right, getting well past that into the muscle, organs, bone, etc. And so here's a really nice chart that I find helpful. So looking at, again, kind of as an easy reference tool. So here you have your superficial burns where it says, for example, again, it's going to be our sunburns, but also things like flame exposure and short flash. So if you've ever seen somebody got a little too aggressive with the lighter fluid while trying to light a barbecue, and then they had to kind of step back and then a little singed, right, a little bit singed on the eyebrows, a little bit red in the face, that's your classic superficial. Then you have your superficial partial thickness or your second degree. So again, we've got our blisters. Again, it's going to hurt. Now what you'll notice is, and what's very interesting is, so that deep partial thickness, right? So this is going to be so significant burns with grease fires, oil, etc. And so you'll notice that it says sensation is perceptive to pressure only. So you saw in the previous diagram, we've actually burned, in our third degree burns, we actually burned below the nerve endings. So at first, until the nerves regenerate, they don't hurt. Which is really weird. You can only feel the pressure, but you can't feel the initial pain. And again, then we're looking at a significantly long period of healing time with a risk of contracture. And then our full thickness burns. So again, where we've got all the way down possibly to the bone. And so again, so these don't, because all of the tissue is removed, these aren't going to heal. So in which case, what this is going to do is, right, this is why we're going to need skin grafts, etc., because it's not going to heal on its own. And again, so perceptive to deep pressure only. Now again, as it heals, or right as we do skin grafts, etc., the feeling does return, right, and it's incredibly painful. But I think it's just kind of very psychologically very strange that at first they may not be able to feel that sensation. So again, our pathophysiology, so extensive inflammatory process with rapid fluid shifts and accumulation and fluid loss from the wound. So you've seen, for example, again, your classic blister. You see fluid get, right, changes compartments. And then especially then if the blister pops, right, it's now oozing or weeping. So you're losing fluid, but imagine that on a much larger scale, so a significant portion of the body's burned. Metabolic stress with hypermetabolism, catabolism, altered immune and hormonal response. And respiratory complications may occur due to inhalation of smoke or other toxic substances, or as complications to fluid resuscitation, inflammation, pain, and infection. So the treatment, so topical antimicrobial agents and barriers to prevent infection. So for long periods of time, we've used silver sulfadiazine, which is it's basically like an ointment, and silver nitrate. And so the probably the hardest thing about burn units, right, is the cleaning and debriding and dressing of wounds, which is you'll see it is not pleasant. You don't want to work burn units unless it's really a calling. It's pretty rough stuff. You have to really scrub and remove the slough. Again, they want to make sure that the wounds aren't getting infected. It's very physically painful, and so they'll give patients significant quantities of morphine and Dilaudid before they undergo the treatments. But even then, it only helps so much. So this is some rough stuff. So keeping the wounds covered to reduce nitrogen or protein losses and prevent infection. And again, skin grafting or skin substitutes for full thickness burns. So again, we said that those fourth degree burns will require some kind of graft or covering. Again, they're not going to heal on their own. I strongly recommend that you take a look at, there's a really cool article. I normally would show the YouTube video, but it's not hard to find, which is look at, so fish skin for the treatment of burns. So ideally, right, we can do skin grafts for everybody, but the problem is that especially in if there was a crisis or an emergency, so for example with 9/11, if there's ever a large number of people that need them, it's simply not an option. And so there was actually some pretty creative science coming out of Brazil, so looking at alternatives for skin grafts and looking at wet wound healing. So I would encourage you to look it up at on YouTube. It's only 3 to 4 minutes long, but look at fish skin and burn treatments. It's really some cool stuff. So burn patients are at very high nutrition risk. So 20% of body protein can be lost in the first 2 weeks after an injury. So these patients are hypermetabolic. We know they have fluid imbalances, significant pain, and immobility, which makes it difficult to maintain nutrition status. And then wound healing, right? We need to get optimum nutrition, right? So here, more is not better. We talked about this earlier in the presentation. Just giving people extra protein is not the answer. We've tried it in these patients. That's not the answer. We need to give them plenty of protein, but more and more and more and trying to match every single gram they lose has proven to not be the best solution. But the wounds themselves, right, from the fluid and the actual oozing are going to be losing protein and moisture or fluid as well. So our concerns, right, is that our PES statements are going to be things like increased energy expenditure, increased needs, involuntary weight loss, impaired nutrient utilization, altered GI-related lab values, altered GI function, as if they have a Curling's ulcer, which is, again, a secondary condition to this burn. So our nutrition intervention, right, is to first replace fluid and electrolytes, then food. And so fluids need to be included, right, the maintenance fluid plus any losses from oozing wounds. So to give you an idea, and again, if you were trying to figure out, well, the rule of nines is like, that's some cool stuff for understanding TV, but how does that actually help me? So you as a dietitian need to understand the rule of nines. So evaporative water losses of 2 to 3.1 milliliters per kilogram per percentage of body surface burn. So if you have a person who is 100 kilos, so 150% of their body, right? So you have 2 mils per 100, right? Or 2 mils per kilogram, so 200 and then times 50, so you're looking at 100 mils, so you have to give them at least 100 extra mils of fluid. And again, that's just basic evaporation. That's not any oozing, that's just water vapor evaporating off. For energy needs, again, we're going to have indirect calorimetry. We do have a specialty formula, though, known as Ireton-Jones, so this is when I would want you to put that into your pocket guide. So Ireton-Jones does account for burn injuries and vent status, so this is literally the only formula that accounts for burns, so it's kind of interesting. And so we know that calorie needs are going to be increased by 20 to 30%. And so again, we may need more calories depending on if there's any secondary issues, including fever, sepsis, trauma, additional surgeries. And again, what you're going to see is that even once you do the formula, you're like, well, these calories don't seem that high. And again, it's counterintuitive, I understand, but the answer is not more and more and more calories, more and more and more protein. There is a limit. So remember, we've talked about this ad nauseum in class, that law of diminishing returns, which is we can only keep giving and giving so much before it actually causes negative side effects. So looking at our protein, so somewhere between, we said 1.5 to 2 grams per kilogram, and then about 20 to 25% of total calories. Again, we want to base this on the most accurate weight we can attain. We know that it's not going to be perfect because of fluid shifts, right? If we've had to use fluids for hemodynamic stability or fluid resuscitation. So we're going to do the best we can, controlling for hyperglycemia due to the stress response. And then we know that our micronutrients, vitamin C, E, A, and zinc may be included, along with careful monitoring of our electrolytes, sodium, potassium, phos, mag, and calcium. And of course, our long-term goal is to wean from nutrition support to a PO diet, depending on, of course, so what part of the surface area of the skin is burned, if there was significant smoke inhalation, damage to the esophagus, trachea, etc., or right if they're able to transition to a PO diet relatively quickly, And again, our PO supplements things like Ensure and fortified foods to increase calorie and protein intake. So again, we said nutrition support, so early enteral nutrition is recommended. So again, it's ideal to transition to that oral intake as soon as possible, but we do want to use enteral nutrition as soon as we can, right? As soon as it's safe to do so. So enteral nutrition initiated within 24 hours of injury, associated with the prevention of infections, prevention of the Curling's ulcer, and reduction of protein breakdown. And so again, this is a special type of ulcer, so of the gastric or duodenal tissue due to severe trauma or burn. And so this is treated with antacids or proton pump inhibitors. So it's a special type of stress ulcer, which is we put so much stress on the body that we actually then have damage to the intestinal or gastric mucosa. And so we prevent this with early feeding and then antacids and or a proton pump inhibitor to prevent this. So again, consider a high protein formula with glutamine and omega-3s for, again, that reduction in inflammation. And I cannot stress this enough, do not overfeed. It's very counterintuitive. You would think, oh, they're losing so much, just give them more, give them more. But that's actually not the best strategy for good outcomes. So again, we have a nice little summarized cheat sheet. So things to focus on, so minimizing metabolic stress by controlling environmental temperature, maintaining fluid and electrolyte balance, controlling pain and anxiety, and covering the wound. So it's all going to be performed by the medical team. But again, you're going to hear about those treatments when you go to rounds, right? They're going to be discussing, hey, we're using the hypothermia protocol or the hyperthermia protocol, which is either we need to cool the patient off or heat the patient up. Or we're going to be we're using this kind of sheeting to warm the patient up or cool them down or prevent moisture losses. So you're going to hear all of that in rounds. And then our job is to meet nutritional needs, so providing adequate calories to prevent the loss of greater than 10% body weight, providing adequate protein, again, not excessive, and providing vitamin mineral supplementation as indicated, and the prevention of curling ulcer by using a combination of antacids and continuous enteral feeds. All right, so now we'll go into surgical intervention. So a surgery, so an operative procedure used to diagnose, repair, or treat an organ or tissue. And so I think the big thing, Ryan, is that we normally think of surgeries as being like, oh, I have to fix something, but realizing there's actually several different reasons that we can do surgeries. So even, for example, if we're looking to do invasive biopsies, right, and diagnose an illness, right, that's still a surgical procedure. We can repair a damage, which is what we're normally thinking of, or it can be, right, a recurring therapy if we need to correct something. So surgeries, right, are going to be classified by their seriousness. Is it minor or major surgery? And is it necessity? Is it elective or emergency surgery? So for example, what you've seen actually is that many hospitals, and I'm sure you've seen this in the news, for example, is that Sarasota Memorial had to furlough nurses. And so what they've actually done is there's no elective surgeries, which is, elective is always kind of one of those funny words because elective now, but it might be an emergency later in the future, or it could truly be elective, so things that are cosmetic, etc. But basically what they've done with all the hospitals in this current corona crisis is that if it can wait, it's going to. So, right, we're not performing elective surgeries. We are still performing emergency surgeries, which is if I don't do the surgery, they're going to die, right? That has not stopped. Emergency departments have not stopped working. So we were also looking at the specific purpose of the procedure. So again, is it diagnostic? Is it excision, palliative, reconstructive, or a transplant? So many surgeries, it sounds crazy, but they don't pose nutritional risk. So there are certain implications that can occur with some underlying or some coexisting issues, but for the most part, if I break my leg, I go into surgery, they fix my leg, I come out, they give me a dinner that night, you're not really at nutrition risk. So, now implications can occur though if the patient is already malnourished when they first go in, or if they're overnourished, aka, right, overweight patients actually are at increased risk from complications due to surgery. If the surgery is going to interrupt normal nutrition processes, so for example, a throat surgery, stomach, or a GI surgery, preoperative changes in weight, abdomen, or CRP, so again, were we inflamed or malnourished before going in? Anybody over the age of 85 is advanced age for surgical interventions, and any coexisting nutrition-related diagnoses prior to surgery. But for example, it's really confusing. So when we take a look at, for new dietitians, when we take a look at, for example, things like hip fractures. So hip fractures pose significant medical risk, right? So our patients are at very high risk for morbidity and mortality 1 year post-surgery. So we've done a lot of improvement, and I want to say the mortality rate has come down to 30%. It used to be as high as 50%, which is i.e. you get a 50-50 shot of living for a year after a hip surgery. Those numbers have drastically improved with some quality rehab programs, etc. But those patients are at significant medical risk of comorbidities and complications. But if you go in, you get your hip repaired, you come out, you eat 100% of your tray, and oh, by golly, because you're a little bit older, we gave you an Ensure, and you drank it all. And so you're getting 100% of your daily needs met, you're getting your extra protein, you're getting your extra vitamins. As a dietitian, what more can I do for you, right? You're not really at medical risk. I'm sorry, I apologize. You're not really at nutrition risk. You are still at medical risk, but there's nothing a dietitian can do for you. So, and it's really hard to accept, right? That's the limits of our scope of practice is that someone can be at significant medical risk, but there's nothing more that we can do on the nutrition side for them. So clinical manifestation, so it depends on the type of procedure. Patients may have nasogastric tubes for secretions, and so what will happen is they may actually have a tube placed just for suction. So the tube will actually be down either in their stomach, or it could actually be a wand that they use for the back of their throat. And what the purpose is actually just to manage their secretions, so they in essence don't choke on their own fluids, right, and have any aspiration, pneumonia, etc. So anesthesia may develop as a post-op ileus, so again that paralysis of the gut. So this will typically resolve in 24 to 48 hours, and so we can resume intake when we have bowel sounds and gas production. So this is the infamous, right, they won't let you eat, or they won't let you leave the hospital until you produce gas, or until you have a bowel movement. And so this is the reason why, is they want to make sure that we don't have paralysis of the GI tract. So nutrition therapy for post-surgery. So nutrition assessment, so energy and protein requirements, right, should be established individually and should support post-op healing with appropriate activity and injury factor, right? Most of these are going to be bed-bound, so that activity factor is almost always going to be 1.2. But there's right, if it's truly a significant surgery, but things like knee replacements, etc., they actually will be ambulatory and walking the same day, in which case that activity factor goes up to 1.3. If there's metabolic stress, again, we need to address that. So again, taking a look at hyperglycemia, caloric needs, etc. And possible diagnoses include increased energy expenditure, inadequate intake, increased nutrient needs, and altered GI function. Now, what we will talk about is the pre-surgery diet. And so historically, what you'll see is the medical order is NPO after midnight. Now, we are slowly getting rid of this because we know all the way back from our chapter on lower and upper GI MNT, we know on how quickly the digestive system actually digests nutrients. So the concern is that if you have food in your stomach and then you undergo anesthesia, it is possible that you would vomit and aspirate that food into your lungs. But we know how long it takes food to exit the stomach. So NPO after midnight is probably great if you are the first surgery of the day. You're the 5:30 surgery, you're the 6 o'clock surgery, etc. But if your surgery isn't until 3 p.m. and you're NPO after midnight, you're going to go 15 hours without food. When in reality, and so what you'll see is the transition to is we want to withhold solids for 6 hours and clear liquids for 2 hours prior to the induction of anesthesia. So this has shown improved blood glucose control, decreased nitrogen losses or loss of lean body mass, and it helps preserve strength. So again, if you are the 3 p.m. surgery, you can eat breakfast, not eat lunch, and still be in compliance. If you're the first surgery of the day, you should be NPO after midnight. And so what we should be doing is looking at these patients and treating them as individuals rather than these blanket policies. So patients should be allowed to take fluids up until a few hours before surgery, and carbohydrate-rich beverages prior to surgery actually help control blood glucose. So things like Gatorade, etc. Your blood sugar would actually normally drop during surgery, so having carbohydrates beforehand actually helps maintain blood glucose stability during the surgery. Post-surgery, progression of post-operative feeding should be individualized. So the goal is to progress from NPO to solid foods as soon as possible and avoid being on clear liquids for any extended period of time. And again, a lot of evidence actually suggests we may not even need clear liquids. We should really just be able to advance as tolerated. And if oral feeds aren't possible, then again, determining the appropriateness for enteral feeds, right? So if we're anticipating complications, then perhaps we actually want to consider enteral feeds and placing the tube during the surgery. Early enteral nutrition if the GI tract is functional with an immune-enhancing formula. And again, so a GJ tube may be placed, you may see this present, where again, the gastric portion of the tube is suctioning, right? So looking at the blood, mucus, etc. from a surgery is being sucked out of the stomach. And then nutrition is actually being placed into the small intestine, into the jejunum. And so you can here you can see just kind of a little graphic, so looking at the hypermetabolic response and the different disease states, and looking at major concerns and management. All right, so our practice question, so the metabolic response to stress that occurs immediately after injury and is associated with hypovolemia, shock, and tissue hypoxia is the blank phase. So again, remember, this is our adaptation. This is our stress response. So there are 3 phases, and the correct answer is answer choice A. This is the ebb phase. Number 2, during stress, blood glucose levels are usually, and this is answer choice B, elevated. So remember, we develop insulin resistance during stress, so we will be elevated. Answer choice B. Number 3, which of the following therapy is associated with maintaining tight junctions? And so remember, tight junctions refers, right, we're looking at trophic factors, and we're looking at the mortar that holds the bricks tight together. So this therapy, this is answer choice C, enteral nutrition. Number 4, the release of cortisol in response to stress increases all of the following except. So which of these is not increased during cortisol? And that is answer choice D, insulin release. So we develop insulin resistance and our blood glucose goes up. We do not release extra insulin. So it is answer choice D, we do not release extra insulin. Number 5, the most valid equation for estimating energy expenditure in adults with burns. And so again, this is a unique equation that incorporates both burns as well as the ventilator or breathing machine. And so this is answer choice C, the Ireton-Jones formula or equation. That is answer choice C, the Ireton-Jones formula. All right, so that concludes this lecture. I thank you for your attention. I look forward to your questions and our discussion on Tuesday on metabolic stress.